I bring warm greetings from the World Gastroenterology Organization and honorary distinct professor as the Tamil Nadu Dr. MGR Medical University and further greetings from Medindia Hospital and Academy. So, having greeted you, why this fourth series on international webinar? The first three series we saw delegates from all over the world, over 19,000 delegates attended. That mainly happened during COVID time. That really inspired us. Why not we have the fourth series? And this is come with the tagline, name the topic, the world experts are here. And that is created a wave called New Endo-G webinar series. And the fourth series is from April 2025 to March 2026. That is 12 webinars monthly. The fourth Thursday of every month, we are going to have it. So this is what the webinar. And the third series was inaugurated by Professor Dr. Jonathan Lighton, the president of American College of Gastroenterology, and got endorsed by American College of Gastroenterology. Now, one of the series really saw the witnessed the high profile scientist, Professor Dr. Barry Marshall, Nobel laureate, discoverer of Helicobacter pylori, and he talked on the journey of discovery of Helicobacter pylori and further that attract the attention of several thousand delegates from all over the world. That's one of the fantastic session we had. Those who want to have the link can email to us. We will send you the link also. And these webinars would not have been possible without the help from my colleagues, Dr. Gokul, Dr. Satya, Raja Yogesh, Dr. Prasad, and Trinyana Samandam. And these 12 webinars in this fourth series, and what we have seen is we have the national faculty and international faculty, just to show the glimpses of who are the national and international faculty. We have, apart from Dr. The David Haas and Harris and the Vivek Sandeep Seth Groh and so many other people, and national eminent faculty, Dr. Nagireddy, Shiv Sareen, Dr. Andir Sood, and that A.C. Anand, and difficult to tell all the names of this faculty. And this was very successful because of the eminent people start moderating, and we welcome the people who have done the original work as the panelist also now. And the 12 webinars, what we have done here on type 2 diabetes mellitus and diabetes and GI tract, systemic hypertension and portal hypertension, and current management of dyslipidemia and fat and liver, and pharmacotherapy of obesity and endoscopic surgical management of obesity now. And other lectures going to be in the webinar session. We are going to have doctor and law and doctor and ethics and doctor and research and doctor and research forum, and that is all very interesting topic, and doctor and finance, doctor and entrepreneurship, and research methodology. We have part 1 and part 2, and a masteral checkup in gastroenterology, pre-cancerous lesions in gastroenterology, and we are going to have a live workshop on February the 2021-22, and finally we are going to have a debate, endoscopy versus surgical gastroenterology, and a physician perspective and surgeon's perspective. And current topic is going to be on pharmacotherapy of obesity and endoscopy surgical management. And this is my pleasant duty to introduce my faculty. The first speaker is Dr. B.J. Gokul. He is a pharmacology medalist during MBBS career. So he's got a very special interest in the pharmacology. He is a medical director of Medindia Hospitals, and he is the winner of the Video Champion Award by the International Digestive Diseases Forum Hong Kong, and Video Competition Awardee in the World Congress of Gastroenterology Istanbul, and a special invitee in the United European Gastroenterology Week, Vienna. And his areas of interest is advanced therapeutic endoscopy and the third space endoscopy. We welcome you, Dr. Gokul. And this is going to be moderated by Dr. Pooja Singhal. She is the founder and director of Oklahoma Gastro Health and Wellness USA, board member of Oklahoma Country Medical Society USA. She is currently the GI Chief, Lakeside Hospital, and ACG Governor, Oklahoma State. And here, special interest, watch out that women's gastrointestinal health and obesity medicine. I think now you are going to specialize in obesity medicine, and he is an awardee of American College of Gastroenterology Young Physician Leadership Award and the four-time recipient of the National Scopy Award for raising colon cancer awareness in Oklahoma. And the second speaker is Dr. Mohit Bhandari. He is a well-known name in India and many parts of the world because of his tremendous number of work and the kind of the volume of work he has done in surgical endoscopy, that is the bariatric surgery, and then he started doing the endoscopy surgery. He could balance himself that which is better for the patient. He is the director of Mohat Pediatrics and Robotics Indore, is in the central part of India, director of Bandari Hospital and Research Center, president of all the societies, various societies is there, and recognized as the youngest and most experienced bariatric surgeon, and among the first surgeon in India to perform robotic bariatric surgery. And he has got many things to his credit. First, perform a single anastomosis, duodenal ileal switch, and international surgeon award from the American Society. So, who will get better? Who will be witnessing better than him to speak on bariatric, the endoscopy and surgery? And usually we have another eminent doctor, Dr. Pichamal Dirapinio. She is assistant professor of medicine at Harvard Medical School. Everybody dream is to enter into Harvard, and the director of bariatric endoscopy fellowship at Brigham and Women's Hospital, one of the first gastroenterology in the USA to be triple boarded. That is internal medicine, gastroenterology, and obesity medicine. Internationally recognized thought leader in the medical and endoscopic treatment of obesity and fatty liver disease, and recipient of ASGE Research Award, ACG Outstanding Research Award, and has got numerous publications to her credit. We have very eminent panelists starting from Professor Tantan and from the professor and head department of gastroenterology, from Myanmar, and Evaristus, Dr. Evaristus from the consultant gastroenterologist from Nigeria, and our own student, Dr. Deji Jai, I think he'll be joining anytime Department of Medicine again from Nigeria. With this, my job will not be over if I don't mention the names of the ambassadors through whom this all this webinar became very popular. I could see Dr. Nirmal Singh from Punjab, Rajiv from Maharashtra, and I could see the other Praveen Kumar from Kerala, and we have other faculty from each state of India, and we have international ambassador from USA, Malaysia, Nepal. Dr. Sitaram is there now, right now, and UAE and Australia, Nigeria, Sri Lanka, and so on. So with this, I will introduction, what is this international webinar, what is the ACG endorsement here, and why we are doing every month, and how it has become so popular. Now I welcome Dr. Pooja to introduce the topic and invite the speaker to start the topic.
Thank you so much, Dr. Chandrasekhar. Greetings, everybody. Namaste. It is truly an honor to be here and to be invited to be a moderator for this very, very, very important topic. As we all know, obesity now is a global epidemic. Over 1 billion people were projected to be affected with obesity, according to the World Health Organization numbers in 2023. And these numbers continue to increase and alarm us. Furthermore, there are limitations, as we all know, of lifestyle modifications in the world of obesity, as we recognize obesity as a very complex disease. So the role of pharmacotherapy has really highlighted the effectiveness and the value of a very important treatment option in obesity to enhance weight loss and maintain it. So it is truly my pleasure to invite Dr. Gokul to talk about this very, very important treatment option, which is going to affect all of us as we treat our patients globally. So, Dr. Gokul, please start your lecture on this very important topic.
Hi, good evening, everyone. Thank you, Dr. Pooja Singhal, for the introduction of the topic. Thank you, Professor Dr. T.S. Chandrasekhar, for the kind introduction, and also for giving me this opportunity to talk in this esteemed August forum, because it's August audience. So I was just wondering how I was chosen to give this talk on the pharmacotherapy of obesity. Apart from the pharmacology medals, which Professor mentioned about, probably I thought my BMI of around 20 worked in my favor, and that is one more reason why I was chosen. I would like to disclose here that I'm not on any of these medications for maintaining my body weight. So let us go to the topic, pharmacotherapy of obesity. So statistics says that about 16% of adults over the age of 18 are worldwide obese. And more than 1 billion people, as Dr. Pooja Singhal mentioned, are living with obesity as of 2024. And the prevalence of obesity has tripled since 1975. And there's a rapid rise of obesity in low and middle income countries due to urbanization, processed food consumption, and sedentary lifestyles. The global cause of obesity is also rising. In India, at least, we have this data from the National Family Health Survey, which shows that the prevalence of obesity is 6.4 of women and 4.4% of men are obese between the age of 15 and 49. And there is increase in the incidence of prevalence of obesity in children, even in children less than 5 years. And we see that it was 2.1 earlier and it is 3.4 now. You're all aware of the obesity complications, apart from the complications like NASH, hypertension, diabetes, and dyslipidemia. We also have other problems which comes with obesity, like osteoarthritis, increased incidence of stroke, depression, and cancer of the breast, colon, liver, and pancreas. Now, the benefit of weight loss is substantial in terms of comorbid conditions. As you see here, weight loss of as low as 2.5% has a beneficial effect in terms of improvement of blood glucose and lipids, and the benefit extends linearly up to weight loss of 15%. But as you see here, there is a improvement of comorbid conditions when there is a weight loss between 5 and 10%, as you see in this slide. What are the methods of achieving weight loss? The lifestyle modification causes modest weight loss of 3 to 5%. But when it combined this with pharmacotherapy, traditionally it has been told that the weight loss could be 5 to 10%. But then with the latest available GLP-1 agonist, it could be even up to 20%. Of course, nothing beats bariatric surgery, which is a time-tested method, 25 to 30% weight loss over 1 to 3 years. The typical indications for starting these drugs would be when a patient with a BMI of more than 30 or with a BMI of more than 27 with one more comorbid conditions like hypertension or diabetes, when there is a failure of lifestyle therapy to achieve the desired weight loss, or when there is a weight regain after initial success. These are the typically approved anti-obesity medications available in the market for non-syndromic common garden type of obesity: orlistat, the combination of phentermine topiramate, naltrexone bupropion. We have this GLP-1 agonist like liraglutide and semaglutide, and dual agonist tirzepatide in the market. We also have one drug set, melanotide, which is available for treating syndromic obesity, like which forms a part of syndrome like Prader-Willi syndrome or Bardet-Biedl syndrome. So typically, the orlistat is a peripherally acting drug compared to the centrally acting drug like the combination, which I told you earlier. And we have this GLP-1 agonist, which acts on both, which has got both central and peripheral actions. The orlistat is an inhibitor of gastric and pancreatic lipases. So typically, when the patient ingests fat, The lipase and from the stomach as well as in the pancreas gets bound to the fat and causes breakdown of fat. But this is prevented by giving orlistat, which actually binds covalently to the lipases, preventing it from getting attached to the dietary lipids. So that is how the dietary lipids are not getting absorbed when this drug is administered. Typically, the dose is 120 milligrams given along with meals or within an hour of meals. Fat-soluble vitamin supplementation is must, typically spaced by 2 hours. It is renal safe, but not to be given in patient with obstructed bile ducts and not in pregnancy as well. To be avoided in patient who have got cholestasis and malabsorption. The adverse effects are GI, predominantly steatorrhea and fat-soluble vitamin deficiencies. Very rarely, hypersensitivity can cause hepatotoxicity as well. Oxaluria is a problem because whatever dietary fat not getting absorbed reaches the colon, that gets bound to calcium, and we have less calcium available to bind to oxalate, and so more oxalate gets absorbed, leading on to oxaluria and renal failure in some patients. So this is the efficacy. It has got a modest efficacy. The placebo subtracted weight loss of 2.3 kg with 1 year of treatment in one study and 2.6 in another study. And the odds ratio of 5 and 10% weight loss is 2.7 and 2.4. Not only there is a reduction in BMI, but it also a reduction in waist circumference and lipid levels as well. Coming to the fixed dose combinations, phentermine and topiramate, predominantly these drugs act in the hypothalamus. As you see here, the pro-opiomelanocortin pathway, which is when activated, secretes alpha MSH, and this actually stimulates the melanocortin 4 receptors, and that is how the appetite is lessened, and there is an increase in energy expenditure and leading on to the weight loss. We also have the beta endorphin mediated autoinhibitory loop, where the naltrexone acts, which I come to it subsequently. Phentermine is a sympathomimetic amine. It suppresses appetite by increasing the norepinephrine levels in the brain. This norepinephrine acts on the beta receptors of the hypothalamus, causing suppression of the appetite. Topiramate, you're all aware, is an anticonvulsant drug with a multitude of actions. It acts on the GABA receptors, causing a reduction in craving and food intake. It also inhibits the carbonic anhydrase, which leads to mild metabolic acidosis, which suppresses appetite. Interestingly, it causes dysgeusia, especially to carbonated beverages, and also improves insulin sensitivity. It helps in weight regulation as well. So these are the strengths available. The lowest strength is 3.75 of phentermine and 23 of topiramate. The maximum dose is 15 milligrams and 92, typically taken in the morning to prevent insomnia. So the dosing is, we have to begin with the lowest possible dose given for 2 weeks, then double the dose to 7.5, reevaluate in 12 weeks. If there is less than 3% weight loss at the end of 12 weeks on 7.5 mg dose, we have two options, either to discontinue or escalate the dose to 11.25 milligrams of phentermine given for another 14 days before escalating the dose to the maximum dose of 15 milligrams of phentermine. Now, if 5% weight loss is not achieved with 12 weeks of this maximum dose, then we have to discontinue the drug by gradually tapering the dose to prevent seizures. Now, the renal dose and the dose in moderate hepatic impairment is 7.5 milligrams of phentermine, but we don't have data for severe hepatic impairment. It is not to be given in patients who are pregnant and those who are breastfeeding. Now, this efficacy of this drug is actually studied in this Concord trial, where 8.6% weight loss could be achieved along with diet and physical activity when given for 56 weeks, compared to 1.2% could be achieved with placebo. We also have a 52 weeks extension trial in sequel trial. So a total of 108 weeks it was administered. Weight loss of 10.5% could be achieved compared to 1.8 with placebo. Meta-analysis showed that the odds ratio of 5 and 10% weight loss was 9.2 and 11.4. So this is the extension sequel trial, which showed impressive 8 to 10% weight loss when given over 108 weeks. The most common side effects are dry mouth, constipation, and paresthesia. Phentermine increases the heart rate. We need to be careful in patients with elevated IOP. Intraocular pressure need to be monitored to prevent angle closure glaucoma. Topiramate causes hypohidrosis, so need to be avoided in patients who are already on anticholinergic drugs. It can sometimes lead to nephrolithiasis. The central side effects are sometimes disturbing, especially the mood disorders, the cognitive impairment, as well as the central nervous system depression. So to be avoided with other CNS depressants like alcohol and other drugs. need to be withdrawn gradually because abrupt withdrawal can lead on to seizures. Coming to the next combination, the naltrexone and bupropion. Bupropion actually is a norepinephrine dopamine reuptake inhibitors, activates the POMC neurons, suppresses appetite. The naltrexone blocks the endogenous opioid-mediated brake. So this is where the bupropion acts. It stimulates the POMC. And this beta endorphin mediated autoinhibitory loop is actually blocked by the naltrexone. So we have a synergetic action here. The dose has to be titrated like any other drug. The week one, we start with 1 tablet a day, then gradually build up the dose until a maximum dose of 2 tablets twice daily can be administered. If there is no 5% loss of weight at the end of 12 weeks, we need to discontinue the drug. The efficacy studied in the one RCT of more than 1,700 patients, where this combination was given for 56 weeks. Weight loss of 8.1 could be achieved compared to 1.8 with placebo. And the meta-analysis showed that the odds ratio of 5 and 10% weight loss was 3.9 and 4.1. No major cardiovascular events could be noted with this combination, though bupropion can cause increase in heart rate and blood pressure. So to be avoided in patients with uncontrolled hypertension as well as hyperthyroidism. It reduces seizure threshold, not to be given in patients with seizure disorder. Naltrexone can cause nausea and vomiting and not in patients receiving opioids. Coming to this GLP-1 receptor agonist, this has revolutionized the way we manage not only diabetes but also obesity. GLP-1 receptors are distributed in the variety of organs. It acts on the hypothalamus by causing reduction of the appetite and increase in satiety. It acts on the pancreas, causes insulin secretion in response to glucose. It acts on the stomach. It causes reduction of the GI motility. It also acts on the liver and fat cells, causing lipolysis and reduction of lipid content of the liver. Now, liraglutide got approval for diabetes earlier compared to its approval for obesity. The dose is actually, we have to slowly build up the dose to avoid the gastrointestinal side effects. We start with 0.6 milligrams given for daily for the first week, then built up by 0.6 milligram every week until a dose of 3 milligram could be achieved. And this has to be continued. Only 5% of weight loss could be achieved after 12 weeks on the maximum dose. Now, scale trial actually looked into the efficacy of this drug and given for 56 weeks. We see that a significant proportion of patients could achieve the 5 and 10% weight loss compared to placebo. You see that the response is slightly low when diabetic patients were included compared to non-diabetic patients. It also had significant benefit in patients with obesity and sleep apnea and also for maintenance. Coming to semaglutide, the dose has got a dosing advantage. It can be given once every week subcutaneously. Again, we have to gradually build up the dose. We start with 0.25 once weekly and go to the maximum of 2.4 milligrams. Now, step trials actually looked into the efficacy of this drug when given over 68 weeks. We have step 1, 2, 3, and 4. Step 1 actually looked at the efficacy on non-diabetic patients. Step 2 in diabetic patients. Step 3 in those where intensive behavior therapy has been given in addition. And for sustained weight management, this is for maintenance, step 4. You see an impressive 14.9% weight loss and 16% weight loss could be seen with this drug compared to placebo. Coming to tirzepatide, which is dual agonist, it acts on GLP-1 as well as gastric inhibitory polypeptide GIP receptor as well. It got approval for diabetes earlier in 22, but for obesity, it got approval in 23 November, and for OSA in December 24. Again, the dose has to be titrated very well. It has to be 2.5 to once weekly in the first 4 weeks, then gradually build up the dose to maximum of 12.5 or 15 milligram once weekly. As you see here, it acts again on the brain, the pancreas, and the fat like the GLP-1 agonist, but the effect is augmented because it acts on 2 different receptors. You see where these receptors are located, the GIP-1 receptors, the K cells of the duodenum and the upper jejunum, whereas GLP-1 is predominantly the L cells of the distal small bowel and the distal colon. Efficacy of this drug was studied in the SURPASS trial, where they evaluated in the role in diabetes and in the role in obesity in SURMOUNT trials. The SURMOUNT trial was actually one in obese non-diabetic patients. You see an impressive 20% weight loss when the 15 milligram dose was used compared to 3% with placebo. You also see that there's an incremental weight loss when given for 72 weeks. The SURMOUNT-2 trial actually studied the effect of this drug in obese diabetic patients. There is an impressive reduction in the HbA1c, as you see here, the 10 and 15 milligram dose compared to placebo. There is a reduction of 13 centimeters of waist circumference when this drug was given over 72 weeks. So the adverse effects are the one that actually prevents us from giving the full dose, or actually in some patients. Nausea happens at least in 20 to 40% of patients because it reduces the gastric motility. Vomiting, abdominal pain, constipation, or diarrhea can happen in 15% of patients. So we need to slowly titrate the dose and give administer only, advise the patient to take only small meals. There are some uncommon complications like pancreatitis, which can happen in 0.1 to 0.2% over 1 to 3 years. So we need to avoid this drug if there is a previous pancreatitis, high triglycerides, or there is a pre-existing gallstones. Cholelithiasis, with any weight loss drug, cholelithiasis and cholecystitis can be a problem. There are some absolute contraindications, especially if there is a family history of medullary thyroid cancer or MEN2 syndrome, because studies in rodents have shown that there is an increased incidence of thyroid tumors. So we need to avoid these drugs. When there is a history of hypersensitivity or severe gastroparesis, related contraindications of pancreatitis, pregnancy, and diabetic retinopathy, because rapid weight loss and reduction in the blood glucose can worsen diabetic retinopathy in some of these patients. So this chart actually shows the efficacy of these drugs. As you see, orlistat on the left hand has got a modest weight loss of 2 to 4 kilograms compared to the tirzepatide, which can achieve a weight loss of up to 20%. Now, this is a drug which might get approved next year for weight loss. It is amylin analog, synthetic analog of amylin. Amylin is actually a 37 amino acid hormone co-secreted with insulin, but it degrades quickly. But this analog is got more stable and long-lasting. So the dose is very typical, similar to semaglutide. It is to 0.25 milligram to begin with in the first 4 weeks and gradually build up the dose to the maximum of 2.4 milligrams. Amylin has got a variety of actions. It acts on the pancreas, it acts on the stomach, reducing emptying, reducing food intake by acting on the hypothalamus, and also causes vasodilatation. It has got beneficial effects on the bone as well. Now, the REDEFINE 1 trial in non-diabetic patient showed the estimated weight loss of 20% with this cagri-sema, which is a combination of cagrilintide and semaglutide, compared to 3% with placebo. We also see significant proportion of patients could lose 5, 10, 20, or 25% weight loss with this drug compared to placebo. The REDEFINE 2 trial actually was studied in obese type 2 diabetic patients, 13.7% weight loss compared to 3.4 with placebo. And almost three-fourths could reduce their HbA1c to less than 6.5 with this drug. Now, comparing these drugs, we have this network meta-analysis which came in 2016 before results of the data of semaglutide or tirzepatide were available. So this study showed that phentermine combination to be the most effective of 8.8 kg weight loss. Least effective was orlistat. And similarly, coming to adverse events, this GLP-1 receptor agonist causes more adverse events. When we want to compare liraglutide and semaglutide, the results of STEP 8 trial, it shows impressive 15.8% weight loss with semaglutide compared to liraglutide, clearly showing that semaglutide is scored over liraglutide. Comparing sema with tirzepatide, we have this study where 20% weight loss was seen with tirzepatide compared to 13% with semaglutide. Similarly, the impressive loss of waist circumference with tirzepatide compared to semaglutide, clearly showing that tirzepatide is a winner. We also have other possible indications where these drugs could be used as an adjunctive treatment with intragastric balloon or with endoscopic sleeve gastroplasty, and also in post-bariatric weight gain. We have this study where they looked into efficacy of drugs with intragastric balloon. When they studied, the weight loss, the total body weight loss was similar at 6 months, but at the end of 12 months, more in the combination group achieved weight loss compared to the intragastric balloon alone. And a significant proportion could achieve more than 10% total body weight loss as well. So concluding that combination works better in causing less weight regain after balloon removal. Similarly, this drug is studied in patients who already had endoscopic sleeve gastroplasty. These drugs were studied, phentermine combinations, orlistat, and GLP-1 receptor agonist. What they concluded was interesting. Compared to the group which where the drug was started along with ESG. One subset, got the drug at the end of 12 months, and they concluded that those who were started on the drug at the end of 12 months, they achieved a higher total body weight loss compared to those who were on active medications at the time of the ESG procedure. Now, probably the explanation was that the maximal effect of the ESG is seen in the first 12 months, after which there is a plateauing of the weight. And addition of the drug at that point of time actually potentiates and sustains the weight loss. Similarly, the bariatric surgery, following bariatric surgery, weight regain can happen in 6 to 22% of patients at the end of 5 years. And there is a weight loss plateau before actual weight regain happens. And that is the time where these drugs are introduced best. Of course, the GLP-1 receptor agonists scored over other drugs like topiramate or the combination. Now, among these drugs, how to choose the medications? Probably this would actually guide us how to start the drug. The orlistat is preferred in patients who are taking very diet rich in fat, and also those who want to avoid the central side effects, but definitely not to be given in patients with malabsorption, cholestasis, or IBD. Similarly, the GLP-1 agonist and the dual agonist, tirzepatide, which is not mentioned here, could be advantageous in patients who have got a metabolic syndrome and high atherosclerotic cardiovascular risk, but definitely not in patients with family history of thyroid cancers or pancreatitis. Similarly, naltrexone bupropion combination could be very effective in patients who are binge eaters and those with those who have cravings for taking food, but definitely not in patients with seizure disorder, those on opioids or uncontrolled hypertension. Phentermine topiramate could be beneficial in when there is rapid weight loss that is needed, and also for those who are suffering from migraine, because topiramate has got anti-migraine action, but definitely not in patients with glaucoma, pregnancy, or cardiovascular disease. Setmelanotide, of course, it is only to be used in monogenic obesity, not for the common garden polygenic type of obesity. So to conclude, obesity is a chronic disease that carries significant morbidity and mortality. Even a modest weight loss could benefit the comorbid conditions. And anti-obesity medications can achieve clinically significant weight loss when combined with a hypocaloric diet and a physical activity. Recidivism is common after the drug is discontinued, and therefore long-term maintenance could be required, along with lifestyle modifications. The most effective drugs currently available in the market are the GLP-1 agonist and the dual agonist, but the effect could be sometimes limited by the gastrointestinal adverse events. These drugs are also used as adjuncts to endobariatric procedures and typically start up when the weight loss plateaus rather than waiting for the weight regain to happen, and also following post-bariatric surgery weight regain. But when weight loss recurs or becomes refractory, then we have endobariatric procedures or bariatric surgery as other option, which my subsequent speaker is going to talk to. Thank you very much for your patient listening.
Hi, and Dr. Pooja, you can unmute yourself. And I think you would agree with me that Dr. Gokul made an elaborate presentation out of what are the drugs available. And the last very important penultimate slide is so important that when do you use the orlistat and other thing. So we need to have the experience from the West also during the discussion after Dr. Mogan lecture. So you want to make a quick comment before we move on to the second lecture, Dr. Pooja?
Absolutely. Thank you, Dr. Gokul, for that very thorough presentation. And I really admire how well you compare the medications and also compare the evidence base in terms of use of anti-obesity medications in endoscopic bariatric scope, because that is definitely a question that has emerged, is how to use the anti-obesity medications with ESG or IGB. So that was excellent presentation. Thank you for that.
Thank you.
I think now I call upon Dr. Pisamol Derapino to introduce the topic and invite the second speaker so that at the end of both the lectures we can have a lovely discussion, very fruitful interaction. Okay, Dr. Pisamol Derapino, please.
Thank you so much, Dr. Chandrasekhar, and it's such an honor to be invited to be part of this wonderful webinar. Next talk, we cannot talk about obesity without talking about endoscopic and surgical management of obesity. So it's my great honor to introduce my great colleague, Dr. Mohit Bhandari, who needs no introduction, most experienced in bariatric endoscopy and surgery combined, probably in the world. So we're very excited to be listening to his lectures. Dr. Bhandari, the floor is yours.
So, good evening, everybody. At the very outset, I would like to thank Professor T.S. Chandrasekhar for giving me this opportunity. It's been hard these days to travel for conferences, and I've been avoiding travel for quite a long time now. But when this invitation came, I thought that I should avail the opportunity to interact with all the esteemed guests and talk about the kind of work we are doing. So thank you very much again for having me here on this platform. I've heard that there are a lot of gastroenterologists and a lot of physicians who have joined in. So welcome and thank you again. So I've been asked to talk about endoscopic and surgical management of obesity, and this is my center here in Indore. We have a huge training center known as IRCAD India now. So all the gastroenterologists who look forward to train themselves in advanced endoscopy, including robotic endoscopy, we would be the only center which would be providing that training next year in 2026. So I hope to invite all of you to one of the largest animal labs in the country, one of the most equipped also. These are my disclosures. I work with Professor Manuel Galvao Neto. Manuel is a very gifted gastroenterologist and an endoscopist who developed the field of bariatric and metabolic endoscopy across the world. In fact, anybody in India who is doing bariatric endoscopy has been trained by Manuel Galvao Neto. I can tell you that without any hesitation, and there is no doubt in accepting that. As a group, we have done close to 33,000 bariatric procedures. And when Manuel joined us as the director of bariatric endoscopy here in India, we started doing endoscopic sleeves, swallow balloons, intragastric balloons, and metabolic endoscopy in a very huge way, so much so that now it constitutes 25 to 30% of our volumes. Also, recently we are joined by Professor David Cummings, who is the head of obesity medicine at our center. He visits here every week, every fortnight, every fortnight, and we do training programs for physicians. We talk about obesity medicine, prepare protocols for Ozempic and Mounjaro, and now we are doing trial on retatrutide, so several other drugs in pipeline, and so it has been great working. I think this is very important for us to discuss that we are talking about obesity, which is a very chronic, relapsing and multifactorial disease. It is strongly linked with multiple health conditions. But the problem is that lifestyle interventions like diet, exercise, and behavioral therapy, which are the first line treatment, only would work at a BMI less than 30. And the long-term success with all the other modalities except for surgery is very, very limited. So any therapy which you have to take for chronic disease has to be chronic. And to overcome these limitations, endoscopic and surgical interventions have been developed. And I think these are much more durable and have significant metabolic improvements, which improve not only the conditions, but also the quality of life. Now, there is a big therapeutic gap. Why there is a therapeutic gap? At one area, you have Ozempic and Mounjaro, which are lifelong drugs. These drugs like semaglutide and tirzepatide should not be stopped. The moment you stop them, all the weight gains back. And at the other end of the spectrum, you have bariatric surgery, which at this point in time also would provide 35 to 40% of total weight loss, the strongest treatment on the earth for obesity, which nobody can beat at this point in time. Even though the clinical trials with most of these drugs would say that they offer 15 to 20% of total weight loss, we have seen in actual clinical practice, and I was the first one to present this data, that the weight loss is not more than 12% of total weight loss. So we still have a huge gap between bariatric surgery and the drugs, practically speaking. I mean, We can quote the articles from NEJM and several other journals, but when it will come to clinical application, you would see that even at supra-therapeutic doses, the drugs are not giving weight loss even closer to bariatric surgery. So we have a huge gap, and we have to agree, and that huge gap will be taken over by the endoscopic procedure, because the endoscopic procedure gives much more weight loss than the drugs, but are still 20 to 30% inferior than the bariatric surgery. So what should be our selection criteria for endoscopic therapy? BMI 30 to 40. Anybody less than 30 should be treated by drugs. BMI 30 to 40 is also a very good area for drugs. And that's why we have done marriage between endoscopy and drugs. So drugs have married endoscopy. And so now they work in combination. But for a BMI of 40, absolutely bariatric surgery. There is a lot of data which is going to come, which unfortunately is not being discussed on most of the meetings. But bariatric surgery still remains one of the strongest treatment for weight loss. Now, what do we have in endoscopic management for class 1 and class 2 obesity? Intragastric balloons, the old villain because they have been seen with a lot of disrepute in India. And believe me, the amount of resistance I had to bring Allurion program in India was huge. When I was discussing that with Professor Chuttani, that I want to bring Allurion to India, he told me that Mohit, intragastric balloon in India has a very bad reputation. And I told him that that is because lack of protocol, lack of multidisciplinary team with the gastroenterologist. Most of these balloons are being put by gastroenterologists, and I'm sorry to say, but they do not have multidisciplinary team, having a psychologist, having a counselor, having a mental therapist, having a pulmonologist, dietitian, nutritional therapist, and somebody who can take care of these patients 48 hours after the intragastric balloon is put in. And that's why, because of lack of robust protocols from companies who are throwing in intragastric balloons in this country without putting anti-emetic and antispasmodic and antacid protocols with the hospital, they are just pushing the intragastric balloons. It is going to fail. And that's why when we brought in the swallow balloon program in India with Allurion, and now there are 2 other balloons which are swallowable, which are soon be approved, which will be used. We have a very, very strong protocol for anti-emesis, for antacids, painkillers, hydration, 48 hours after doing these kind of procedures. So this is the therapy. And at the same time, you have something called as the endoscopic sleeve gastroplasty. I think a lot of excitement amongst the gastroenterologists to learn that therapy. But these are very good adjunct to pharmacotherapy. And when you combine them with pharmacotherapy, the results are fantastic. I don't want to go into the details of intragastric balloon. Everybody knows they are fluid filled, they are air filled, they are 12 months, they are 6 months, and several other models exist. But this is our own data of the intragastric balloons, not the swallowable balloons from our center. And we had fascinating data, great weight loss, very less complications, and our patients were very happy. But things changed after I brought in Allurion in India. No surgery, no endoscopy, no anesthesia, 15 minutes of outpatient procedure where you swallow a capsule. It's once it's inside, and radiology confirms that, we fill that the capsule with 550 ml of fluid to convert it into a balloon and remove the catheter. And that procedure has been done with great amount of success in our country. You see the patient entering inside. I explain the patient what it is like to swallow this capsule. I take out the capsule, put a catheter inside, and then this is the capsule. So you can see that the capsule is pre-sterilized, prefabricated, pre-measured, and this is the capsule. And then we put a stillet inside the catheter of this capsule to give it a little bit of rigidity. And with that stillet, I'm going to put this inside or place this inside the back of the tongue, and patient drinks water, and I slowly advance the catheter. We do a X-ray, confirm the position of the capsule inside, fill it with 550 ml of fluid, and then we again confirm and remove this catheter. It's a very, very simple procedure, 5 to 8 minutes in my setting, and we have done it on thousands and thousands of patients, on families together. This is a family, all of them. And why I'm telling you this example is patients have given the consent, so don't bother about the science, don't try and start to complain. This is a family of 5 people, did swallow balloons together. They came to me for bariatric surgery, got scared by reading a news about a death in New Delhi with some other surgeon, and I gave them the swallowable capsule. All of them lost good amount of weight with swallowable capsule, remained a part of my weight loss program, and I converted all of them into bariatric surgery. The message is, do not try and criticize drugs. Do not try and criticize balloon. Keep the patient in the program, and one day they will escalate the treatment from a balloon or from a drug to surgery or from a balloon or a drug to endoscopic sleeve gastroplasty. So this is the story, my dear friends. Endoscopic sleeve gastroplasty again is a very, very good technique. Now with the passage of the learning curve, we have learned to create a very robust tube. Many patients who want to avoid surgery do this procedure. The gastroenterologist should absolutely learn it. I think in this time when you are in 2025, when the market is flooded with GLP-1 analogs, any gastroenterologist who has not learned endoscopic sleeve gastroplasty is doing a big disfavor to his practice. I'm a little blunt because these patients who are on Ozempic or Mounjaro will come after 6 months to you, who cannot afford the cost of these drugs. And now these drugs even will be more costlier because they are going to increase the cost in US. The ripple effect will be the cost of these drugs becoming more in India than in the US. US is coming up with a policy of the drugs being the cheapest in their country. So, you'll see some price increase in our countries where the drug is still cheaper and these drugs are being taken from India to the US. So you will see that you have to learn endoscopic sleeve gastroplasty. It is not equal to sleeve gastrectomy. It's a completely different technique. Whereas in sleeve gastrectomy, we talk about rapid gastric transit. Here, there is a delayed gastric emptying. So the concept is full thickness suturing. And I think we have trained together between me and Manuel more than 500 gastroenterologists. Last year at IRCAD, we did 4 courses. This year in 2026, I mean, the coming year, we are again doing 3 to 4 courses. You can come to us. In a single day, we put you on live pigs to do endoscopic sleeves. And then we take you to the operating room, show you around 30 procedures in 3 days. It's a very exhaustive training we give. And not only this, we are training surgeons across the world on the Vision Pro, our own software. You can log in on my account and post an endoscopic sleeve gastroplasty. I can jump in live through Zoom, which is integrated with our software, and we can train you through the Vision Pro. Between me and Manuel, we have trained more than 200 surgeons across the world using the Vision Pro live while doing the surgery. So this is Manuel training me to do it live and explaining how this modality works of training surgeons through using a Vision Pro device when they are doing a live endoscopic sleeve gastroplasty. Again, endoscopic suturing has expanded the possibility of flexible endoscopy. Now this is going to come in combination with magnets, in combination with robots. So you will have a robotic endoscope. We are working with Beijing Surgical. Now that's no more a secret. Beijing Surgical is installing at least 2 endoscopic robotic systems at IRCAD India. And next year, I would be training a lot of gastroenterologists to learn endoscopic suturing for after ESD and EMR. And it's going to be like the same, like the suturing we do by laparoscopy. And believe me, it's going to be a very fascinating thing. A lot of study and initial work being done by Manuel Galvao-Neto and his colleagues with a different robotic company, but now the Beijing Surgical is going to help us. That's our data of endoscopic sleeve, 2,000 cases. You see phenomenal weight loss of 6 years. This is by far the largest amount of follow-up any single center in India has. At 6 years, 14.4% of total weight loss, 43.4% of axis weight loss at 6 years, fantastic resolution of OSA, dyslipidemia, hypertension, and diabetes. And at the same time, we've published extensively. This is the first Indian experience, and then the 4 years data. And now we are coming up with the 6 years data. We have started doing post-2. The device just got approved. So this is another full thickness suturing device. But what we are doing is not post-2. We are doing something called as the mega pose, which is different from what Gontran Lopez Nova used to do because it was very costly for us to do the pose procedure. But now what we are doing is a mega pose procedure. So you can see we are regularly doing it. A pediatric scope is required. This is my friend Roman Turo, who trained us to do this procedure. And me and Manuel, we got mentored by him. Now we are training surgeons from all across the world to do the mega pose too. It's just 4 good thick plications. And the results are exactly the same with like endoscopic sleeve. So this is something which is the future. I think we will have to devise a strategy where we should be able to train more and more gastroenterologists in the country on this procedure, because now I think that this is approved in the country and a lot of surgeons will listen. Again, the increased availability of anti-obesity medication is influencing both bariatric surgery and endoscopic treatment. But as I have always said, they're going to be complementing each other, not opposing each other. half of my patients who are fed up with drugs go to endoscopy, and half of my patients who are fed up with endoscopy go to drugs, and the remaining half fed up with both do the bariatric surgery. So that's what I'm trying to say. The smartness is not in fighting or trying to debate which is better and which is not. Bariatric surgery definitely remains, as of now, the most strong treatment for obesity, but there is a rationale for combining AOMs with the endoscopic bariatric therapy. And I have published on it extensively. The first publication I did was on the clinical evidence line on ESG plus semaglutide. We have a 25% of total weight loss we published in obesity surgery. And the second one, which we did, this paper is very important. And why? It is important because it's a randomized control trial. At our center, we did a randomized control trial combining semaglutide with a swallowable capsule. One was a placebo, one was oral semaglutide called as Rybelsus. And you see fantastic results. Almost 6% total weight loss difference than 10 and 12 and 13. And every grade, you have 8.9 kilos more weight loss at the end of the follow-up period. So I think, the future is marriage of endoscopy or a swallowable balloon with the anti-obesity medications for patients between a BMI 30 to 40. And because these patients, they are non-surgical patients, they do very good with the combination therapy. And, this is again, semaglutide alone and ESG plus semaglutide. I think fantastic results. You see, there is a difference. So what I'm trying to say is that, number one, all those of the detractors who are trying to say, oh, drugs have good weight loss, there is no role of endoscopy. Believe me, I've been using these drugs since last 6 years now, involved in all the clinical trials. The data from clinical trials of weight loss of these drugs is a little different than the data in real time clinical practice. In real time clinical practice, you have a maximum of 10 to 15% of total weight loss with the drugs, not like the surgery, which has 25 to 30%. But the real-time data also suggests that when you combine these endoscopic methods with AOMs, the weight loss is almost 15 to 20%. So that's going to be the future. And so this slide, which all of you should take back home, 27 to 35 AOMs plus ESG, 35 to 40 ESGs plus AOM, depending upon what is your priority. 27 to 35 AOMs first, 35 to 40 ESG first. Post-bariatric weight regain, again, AOMs plus endoscopic revision, and ineligible for surgery, AOMs plus endoscopic treatment. But anybody above a BMI of 40, please offer them with surgery because bariatric treatment is still the gold standard. I would keep on repeating that. And yes, it is the standard of care in class 3 and class 4 obese, and there are a lot of guidelines on it. I'm not going to go into what a sleeve is or RUOY or one anastomosis. We surgeons, we have this habit of every year coming up with a different bariatric procedure and saying that, my Mercedes is better than your BMW, but every bariatric procedure is almost 25 to 30% of total weight loss. This is a beautiful algorithm. I try and simplify it for you. Patients with GERD, please do a gastric bypass. Don't expose them to GLP-1 or a balloon. You're going to increase the GERD, worsen it to the extent to cause Barrett's esophagus. An endoscopist out there, please, we have been dealing with Barrett's because of sleeve. So a gastric bypass absolutely remains a treatment. You're going to induce the same amount of GERD with a GLP-1 or a balloon. Don't do that. Again, this is 21,205 cases over 12 years from our center. The only published data of the largest series of bariatric and endoscopic procedure. And guess what? All the procedures still standing the test of time. You see 3,000 sleeves, around 3,000 Huawei gastric bypass, around 5,000 one anastomosis gastric bypass, around 2,000 banded sleeves, around 3,000 banded Huawei gastric bypass, around 3,000 or 2,500 banded one anastomosis gastric bypass. Can I tell you, have you seen a series larger than this? I bet you have not. And you see the results at 10 years. Who is showing you 10 years results? I was talking to a group of physicians last evening and I was telling them, let's not talk about the drugs for 5 months or 6 months. Let's talk about 3 years, 4 years, 5 years, 6 years. You see 10 years, 22.4% total weight loss of LSGs in 22,000 cases at 10 years. RUOY 23.9, one anastomosis close to 30%. This is phenomenal. I mean, I don't need to get convinced. I don't think anybody else needs to get convinced. We all know about this, but we do not talk because we do not have data. If we have data like this, which I'm presenting you from a single center, nobody can challenge you because they don't have data. They just talk about, 1 month, 3 months, 6 months, 1 year. Let's talk about 10 years. You see the weight regain data. We have everything in this paper. So I would request even physicians to go and read this paper. Excellent resolution of type 2 diabetes, hypertension, sleep apnea. And I cannot be more emphatic about it because we have been dealing with all the complications also. You see the leak rates, zero leak rates, bleeds in around five leaks, 7 leaks, and 7 leaks is 2,000 cases. But banded procedure, zero leak rates. The bleeds are 34, 12, and 79. I mean, this is something where we need to discuss about our surgical audit also. This is a very detailed report about incisional hernia, internal hernia, marginal ulcers. It's a busy slide. But I would conclude by saying, guys, obesity is a very chronic disease and relapsing disease. So let's prepare today out of this meeting. And I would request Dr. Chandrasekhar that he urges the people, and there are three stakeholders: the surgeons who are the bariatric surgeons, the endoscopist and the gastroenterologist, and the physicians. Let's prepare a obesity board like there is a tumor board. And let's discuss, instead of saying, oh, now we don't need bariatric surgery. A wonder drug has come, which is like a masiha. It's not like that. It never works like that. Obesity is a chronic relapsing disease. You would require endoscopy, you would require surgical method, you would require all the new GLP-1s and now the retatrutide. And it's the most deadly disease of the mankind, the most chronic, the most recalcitrant disease. So let's not fight amongst ourselves. Prepare an obesity board and discuss what's the best for our patient. Also, we should have a database, and I strongly recommend this for your physicians. Please prepare a prospectively maintained database at your center and let your results be guided, your practices be guided by the results of this prospectively maintained database. Thank you very much for this opportunity.
Yeah. Now, Dr. Peshumal, your immediate comment before we start this. At the outset, I will tell you, Mohit, you are just fantastic. And the single center experience that you narrated. And I'm glad that because you have seen using the drugs for over 5 years, at the same time, endoscopic procedure and surgery with the results of 10 years. I don't think anyone can challenge that the kind of results you have that. So you will be, I'm very glad that you are very balanced in the approach and how to choose various modalities of treatment. And we are going to have a real the panel discussion, some exchange of new ideas and your expertise, and how Dr. Gokul is going to, where the drugs have an important role, where endoscopy and where surgery, some of the clarification we need to have that. I welcome Dr. Farooq from Bangladesh. Dr. Pichamal, your comment to start with now.
Yeah, wonderful presentation as always, Mohit. And I just totally agree that there are just so many patients out there for obesity. It's a big pandemic, and there's no one size fits all in the end. Some patients are going to benefit from pharmacotherapy, endoscopy, surgery. So we need to work together, and the goal is to come up with individualized therapy for each patient. So wonderful presentations, and look forward to the discussion with everyone.
Okay, now the panel and the question answer session starts. We start with Dr. Pooja. You can have one question to Dr. Gokul or Dr. Mohit. Then we'll have Pichamal. Then we'll have Dr. Tantan. Then the Evaristus. Then other ambassadors, Dr. Farooq. Yes, Dr. Pooja, your question and comment will start now. We have solid 1 hour so that we can clarify all our doubts and very clear.
So thank you so much. And a big shout out to Dr. Bhandari for that excellent presentation. I really, really appreciated that both Dr. Gokul and Dr. Bhandari has really highlighted the fact that obesity is a chronic relapsing disease that requires a combination therapy, and it's lifelong disease. I think that's where the importance lies for all of us to understand, respect that. So my question, we're taking some questions that were were submitted in an online forum. And I would like to start this question for Dr. Gokul because I do think it highlights a very important thing after these excellent presentations. The question is, who should be prescribing anti-obesity medications, Dr. Gokul?
So when a patient comes to us, I think generally these drugs are being prescribed not only by gastroenterologists, but also by the primary care physicians if they are certified in treating obesity, apart from the endocrinologists who routinely see such patients. So I think it is all three of them who need to be, learning how to prescribe these medications. But in general, it is endocrinologist or the gastroenterologist that who typically prescribe these drugs. Maybe I can have opinion from other people as well.
I think who should not prescribe, very important. It is not a drug where you can give a weekly injection or as Dr. Mogi said, it's not going to be 6-month therapy. And Gokul also emphasizes the long-term therapy. We need to know the side effects of the all medication thoroughly. So who should not do that? It means the one certified for obesity medicine, the one qualified the qualified gastroenterologist, maybe in collaboration with the endocrinologist or a bariatric program who runs a bariatric program. I think both of you emphasized, particularly Mogit said, there should be a program. It is not just like that you do the balloon and forget it. You do the procedure and forget it. Right from counselor, psychologist, psychiatrist, diabetologist, and metabolic syndrome specialist, everyone should be available. And how do you tackle the weight regain and dietary, even if you after deploying the balloon, so the kind of dietary advice you give it also, suddenly start thinking that everything done now, start having the solid at day one, you're not going to tolerate. You will vomit out everything. So we need to have a program. It is not a single man technical procedure alone. So I think, in my opinion, who should not prescribe this semaglutide, the liraglutide or other glutide? Very important. Who is very thorough in the subject, who knows about the side effect and various combination. He has given the. I think one of your slide, Gokul said, adverse effect. According to the adverse effect, suppose the diabetic or some other thing, you should not use this kind of drug. If you have evidence of pancreatitis, you should not use this kind of drug. So should be very thorough before prescribing. Just because they are available in the market, just because you know the new drug alive, and most of the, in my opinion, the obese people, they want to have a shortcut treatment and they want to enjoy immediately and overnight the results they wanted. And in my opinion, again, obesity is a psychological problem, plenty. It is not just like overweight alone. So you have to tackle the everything from the mindset also, willpower, assessment. That means you need to be thorough in that. There should be a division in your gastroenterology. Even the general gastroenterologist cannot prescribe to some extent beyond that unless you get the opinion from the a dedicated physician for bariatric. What do you think, Mohit? Dr. Pooja's question: who should prescribe, who should not prescribe obesity medicine?
So, Pooja, thank you very much for this question. I just want to say that all of us should move away from prescription to subscription. I always say that from prescription to subscription, we have this habit of prescribing drugs. But as you correctly said, instead of prescribe, if we subscribe, where a patient enrolls into a weight loss drug program, and then we have a multidisciplinary team, like you very correctly said. That's more important. Those are the kind of people who can take the responsibility of the patients, because this is a lifelong drug. It's a forever drug, and you might have to escalate the dose of the drug. There can be weight plateau, there can be side effects related to nausea, vomiting, diarrhea, constipation. So I think somebody who has the kind of time, a multidisciplinary team should be prescribing these drugs, and they should be subscribed to the program rather than just prescription on the paper.
Yeah, and
Yes, thank
actually,
you.
there's a
Yeah, it's
paper.
your question and comment. Yeah.
Yeah, no, I totally agree. There's a study in the US and it shows the exact same thing as what everyone mentioned. If the medications were prescribed by a primary care doctor, so no specialty, no subspecialist, without any follow-up plan, no subscription, like what Mohit was saying, the risk of patients discontinuing the medication is much higher compared to if the patients were to get the medication from either gastroenterologists or obesity medicine who have the supporting program. So just some data to support what everyone's saying.
In US, they prescribed by primary care physician.
No, I'm a bariatric endoscopist and obesity medicine specialist. So I do ESG, pose, and prescribe all of the
In fact,
medications.
I saw both of you have some extra degree. I read it. What is that extra
That's
degree?
the obesity medicine
Yeah,
board
similar to
certification.
Pooja. Exactly. So we both can prescribe medications, but I also do bariatric endoscopy.
What is that diploma or the course? 1 year course, is it?
So there are requirements where you took some online courses and then you took a board exam, and it kind of teaches you how to prescribe medications, how to build a program.
Why don't you,
And then you
Mohit,
take a boards. Yeah.
why
And then
don't
you
we start a course in obesity,
Yeah,
both
absolutely.
medical
I
and
think,
surgical, and Gokul
yeah,
can also suggest. Yes,
I think that would be a great thing to start it in India. Dr.
yeah,
Mohit and Dr. Gokul and Dr. Pandari and Dr. Chandrasekhar, I think there's a lot of utility in it.
and
But I
the
did want to say that the importance of the multidisciplinary team in setting a patient for success is very, very important. And all of you guys have highlighted that. But there are a lot of people, a lot of physicians, gastroenterologists who want to do this, who want to tackle obesity, and they just don't know where to start because it can be overwhelming. Because it needs so many foundational pieces. You need a dietitian, you need a good expert psychologist, psychiatrist team, you need a bariatric surgeon or a trained gastroenterologist who knows bariatric endoscopy. So that's why I created my center 2 years ago, and I left actually a very big corporate practice to start this in Oklahoma. Oklahoma is the third largest state with obesity. So I encountered these challenges myself to be able to build a program. So I just wanted to highlight that there are a lot of ambitious, intentional physicians in all aspects, especially gastroenterologists, who are wanting to start this and do this and practice this in the right way. So providing the right method, whether it's a course or more steps through your center, would be very, very good.
I think, and Dr. Mohit, this should move forward. We'll start a course in India where obviously we can get the help from Harvard and Oklahoma governor, that ACG governor is there. They are pretty good in they already we can get the syllabus from their curriculum and everything. So I
yes,
said comprehensive approach to a chronic disease, obesity matters a lot because patients are getting tempted. Just read in the newspaper that Manjaro, okay, I will have a shot and I will reduce the weight, and they come and ask me that, sir, I have taken this injection. So is it all right for him? So that kind of thing should not happen. So I think we need to start a course on obesity medicine, where obesity management course rather than obesity medicine alone. As he rightly said, the combination of at some time or other we are going to have the combination. So next question from Dr. Tantan. How common in Myanmar you are representing? She the president of Myanmar, the Gastroenterology Association. Welcome, President. So what is your take on obesity? And the questions to Dr. Gokul and Dr. Mohit.
Yes, first of all, I would like to congratulate two speakers for your comprehensive review on obesity treatment. And the Myanmar has an increasing incidence of obesity nowadays, but we don't have any sophisticated therapy for obesity. And now we have GLP-1 agonist, semaglutide is popular nowadays because people import it from Thailand and other countries, but it's still very expensive. And so that I would like to know any cost-effective studies between these medicine, anti-obesity medicine and the surgery. And now we are starting. We don't have like stitching devices for sleeve gastroplasty. Now my fellow has studied band ligation. So any experience on band ligation? And then the first question is cost effectiveness study between the medicine and the surgery or endoscopic therapy. And the second question is the endoscopic band ligation.
Dr. Mohit, do you want to take this question?
Yeah. So thank you very much. It's a great question actually between the cost effectiveness. So for the cost effectiveness, I can tell you the Indian scenario because maybe Pooja and Sai can tell you about the US, but I think in India, bariatric surgery is being reimbursed by insurance completely, and the drugs are not. So in the cost they have to bear for a drug for a year, they can easily do bariatric surgery. So at this point in time, when insurance uh, does not reimburse drugs, it's very difficult for patients to take these drugs for more than a year. It's very costly. Although the cost of the drug in India is a bit lower, but the problem, the trick here is when you go to the therapeutic dose of 2.1 of 12.5 for Mounjaro and around 2.1 for Ozempic. There the cost is pretty high. It's like 3 times bariatric surgery, and so that's the problem. So at this point, the cost of surgery is less and it's more sustained. Band ligation, what sort of band ligation are you talking about? Do you band the gastric mucosae? I don't understand because I have not heard about band ligation for weight loss. I don't understand what you're saying, what you're trying to mean for that
Yes,
because
we use esophageal band ligation for band
oh,
ligation.
esophageal band like okay,
Band
esophageal
ligation
band
to
like
the gastric
no. Okay, no. We have no experience.
gastric
We have,
Actually, Dr. Tantan, this is what happened if you do the esophageal band ligation for gastric. What we
Yeah.
use it for the gastric antral vascular ectasia. That is only it takes up the mucosa only, not even the submucosa or anything. So you need to have the shrinkage of the stomach volume and the capacity so that early satiety and all the thing can happen. So if you just suck only the mucosa, that is not going to be very effective. That will not reduce volume of the stomach. The capacity of the stomach will not be reduced. So I don't think any data available, but the conceptually it is not going to fulfill. Okay.
I can comment on the cost effectiveness from the US standpoint. We
Yes.
actually we published a study looking at this specific question in JAMA last year, comparing semaglutide to ESG or endoscopic sleeve gastroplasty. And we show that ESG is 3.8 times more cost effective compared to semaglutide's injection. So very similar finding to what Mohit was saying. So in the end, because the medications are lifelong, it is hard to keep paying for that. So it is more cost effective to do either endoscopic and surgical procedure.
So the long term it is cost effective, but in a given one injection, other thing, I don't think we can compare 6 month injections or 1 month injection with the ESG or whatever the surgical procedure. They have a long term, but that's a one time procedure. Either ESG or you want to do the sleeve gastrectomy is a one time procedure. But here the drugs may be totally contraindicated to have both the surgery and endoscopy procedure. And till we get more data, injection may be preferred. That also we need to have more discussion on that. Dr. Evaristus, your question, please.
Thanks so much, Dr. Gokul and Dr. Bandari. That was a fantastic presentation.
Thank you.
As I was listening, I was looking at people that have obese patients with BMI. When you were presenting, you looked at BMI less than 30. When you have BMI between 30 and 40 kilogram per meter squared, and then BMI above 40 Look, I mean, it was clear that when we have BMI above 40, that we should be talking about bariatric surgery. And you talked about BMI between 30 and 40, we should look at endoscopic procedures will help, and less than 30, that drug, this is where drug could come in, and Dr. Gokul also mentioned that. So my question, and again, from the presentation, I now realize that you could, at a point, those that even started with surgery could, drugs could come in, anti-obesity medication could come in at a point. And those who also started anti-obesity medication, if they're not doing well, sometime you can progress to other forms of treatment. So I look at it as something that where the gastroenterologist will come in, the bariatric surgeon will come in, and then it's something we can coexist in our work. My question is to Dr. Gokul, which of the anti-obesity medications produce the maximum side effect, maximum weight loss? Because you have mentioned so many, Listat, phentermine, topiramate, and all other GLP-1 agonists. Which of these drugs produce the maximum weight
drug
loss?
with the maximum weight loss, the weight loss producing drugs.
Yes.
Dr. Gokul, please.
Of course, as I showed in my slides, the GLP-1 agonist actually produces maximum weight loss. The semaglutide causes, as you've seen, the studies up to 16% weight loss. But then with the availability of the dual agonist tirzepatide, even up to 20% weight loss could be achieved at the end of a year. So as of now, the tirzepatide causes maximum weight loss. We are awaiting the results of the CagriSema, which is going to be available soon. Even that produces a maximum of 20 to 22% total body weight loss at the end of 1 year. So as of now, we have this GLP-1 agonist, dual agonist, and this CagriSema as the most effective drugs currently available in the market. The other combination drugs produces a modest weight loss of around 10 to 15, and orlistat has not been, it produces very, very minimal weight loss, and therefore it is slowly going out of favor.
Gokul, you said there's a combination GLP-1 and GAP that produces the more weight loss?
Yes, the tirzepatide is a dual agonist which produces a maximum weight loss.
So because of the dual action, no?
Exactly, sir. Because
so
of the
what is the maximum weight loss with the drug, best available drug? 22% only.
22%.
22%. I have a question to Dr. Bandari. You see, the morbidity and mortality in your hands are very good because you have done thousands of procedures. So your results of the morbidity and mortality cannot be taken into a new center where they're just starting or they have a modest experience. Suppose you have a BMI more than 40, immediately we said you go for surgery. Can we minimize the morbidity and mortality where people with the smaller experience or modest by giving drugs or balloon? So we bring it down to below 40 or 35. Then you go for surgery. What is your take on that?
Fantastic question. I think yes, it's a very good strategy to downstage the disease. Just like you give neoadjuvant chemotherapy, you downstage the disease. It's like cancer. Forgive me saying that, but obesity is as even more chronic than malignancies. So you downstage the disease with either a swallow balloon or an intragastric balloon, and also it can be beautifully done by both semaglutide and tirzepatide if there are no contraindications to that drugs, and then you make the patient fit for a surgical procedure. I think this is more required for super obese patients where the BMI is 50 or 60. And I do that strategy. For a BMI of 60, I would usually downstage them with a swallow balloon or with a drug or in combination. And when the weight is down, the liver is good, they are breathing well, the renal functions are better, kidney pouring more urine, or the required urine, not more, but the adequate amount of urine, and the edema goes down, we are able to operate these patients in a very nice situation. I've also used endoscopic sleeve gastroplasty to downstage, but now with the availability of these drugs, it's very easy to downstage and then reduce the risk of surgery. Yeah.
I think there is a role for everything. but only thing how judiciously use it. So definitely there is a role for medicine or endoscopy in super obese patients. So before I will go to the second round of talk, second round of the questions. Suppose you do the sleeve gastroplasty, will the surgical will be difficult for you?
No. It's very easy. In fact, Dr. Pishmal is here and she would tell you that most of these patients can be converted into a sleeve gastrectomy or gastric bypass or whatever in a very straightforward way. For the simple reason being, I can tell you, at least with endoscopic sleeve gastroplasty, that most of the cinch which we fire, they are along the greater curvature of the stomach and they come into the specimen. So it's technically very, very easy. For the new suturing device like the Pose 2, the Mega Pose, yes, it's difficult, but if you have an endoscopic access, you can avoid staple misfires and you can even convert them into sleeves and bypasses. But with the endoscopic sleeve gastroplasty, the regular endoscopic device, which I think most part of the world is using now, it's a very straightforward way and very easy to convert it into bariatric procedure.
Okay. Any questions from our Dr. Praveen or Bidan, Sitaram, or Rajiv, Praveen, or Nirmal? Uh, you have any questions to ask?
Yes, sir.
Two eminent. Yes,
Yeah,
Praveen.
yeah. I'll it's fast, sir. My question is to Dr. Gokul. An obese patient is coming. The patient wants the best treatment, whether it's medication, endoscopy, or surgery. What will be your first preference, Gokul?
That's
Patient is confused. We are also confused.
Yeah, that's an interesting question. We usually base our decision based on first the BMI. As we told, the BMI more than 40 straight away goes for, surgery. We need to get a surgeon, bariatric surgeon opinion. If it is between 30 and 40, of course, endoscopic procedures like ESG or balloon has to be considered. And anything more than 30, drug also comes to have a role. Now we have to have a shared decision making along with the patient. We have to give the options, the expected weight loss with each of these medications, and then we will have to take a call. Maybe patient would be initially apprehensive about any of these invasive procedures. We can give a trial of these medications for say 3 to 6 months and see how the weight loss happens. That would give them some confidence. If they fail these drugs, then we have a justification to promote them to more invasive procedures like a bariatric, endobariatric procedure or a surgery. I think we have to take into account these conditions. It is also important to consider other comorbid conditions like the other parts of the metabolic syndrome, which has to be taken into account before giving that decision. Because those with more significant comorbid conditions, we need to offer them more effective options like surgery or an endobariatric procedure than drugs.
Okay. I think to avoid this confusion only, if you superficially look at it, there are too many options are there. But if you really, after attending the webinar or even before that, you will be very clear when to treat it, what kind of everything revolves around the BMI, comorbid disease, and what exactly you want him to understand. The combination, as I told you, Dr. Mohan also agreed, above 40 super obese, you want to reduce the morbidity and mortality or something. Even you can try medication, bring down it. Even if you want, even if you have done it endoscopy treatment, surgery is not that difficult, but for that post procedure, that again he can manage it also. So now things are getting more and more clearer. But one thing is very clear: medicine is for the chronic usage, endoscopy treatment for the medium results, and surgery for one-time long-term results, provided it is done by an expert with the least possible acceptable morbidity and mortality. And obesity treatment is a different ball game. It is not like just treating any other condition. You need to have a full-fledged dedicated team. Dr. Nirmal, your question before we'll start with the puja again.
So my question is Dr. Mohit Bhandari. So now with obesity, we are seeing a great rise in
Your voice is breaking, Nirmal.
associated steatotic liver, which is very much compensated. Okay. So, I'm talking about chronic liver disease with obesity with portal hypertension. So in that case, what will be take of Dr. Mohit Bhandari? Because these people post-bariatric surgery might decompensate, even if they are compensated in the beginning. So here the role of drugs, ESG, or the conventional bariatric surgery.
Fantastic question, Dr. Nirmal. I could not hear you very well, but your question was fantastic. And I think that's an area where we should avoid surgery. See, there's a very hairline difference between improving a liver with surgery or completely deteriorating it. And that's why we often say that, as you correctly said, patients with portal hypertension and who have, cirrhotic liver disease, we should avoid bariatric surgery, and their endoscopic sleeve gastroplasty is a fantastic option. And also you can give it in combination with one of these drugs, both, semaglutide and tirpazetide. But there's just one very important caveat to it, is that these patients should be followed up in a very radical way, in a very strict way, because and we need to have a good hepatologist who can do their liver scans on a regular interval of time, monitor the liver function, because anytime these patients, they lose 15% of total weight within a short span of time. It also may be with drugs, drugs. They can rapidly have progression of their liver disease. So surgery,
Right.
absolute no to surgery. But even if we are giving these drugs like tirpazetide, which are, believe me, strong drugs, especially in a setting where patient have some jaundice and things like that, we have to be monitoring is the key. ESG and drugs are good, but we have to monitor them in a very aggressive way.
Before
Okay.
start puja, Dr. Mohit, you said portal hypertension, doing gastroplasty also very difficult. Start bleeding very heavily because mucosal hyperemia and the portal hypertension, gastropathy, it is not that easy. Even doing a endoscopic procedure.
So I think portal gastropathy one should avoid, but if you have mild esophageal varices which are already taken care of by bending or being taken care by drugs and management, we have done endoscopic sleeve gastroplasty in these patients. Yes, if they bleed, there's a problem, but not gastric varices, but early esophageal varices which have been taken care in a pretty good way. We can do this.
I
We have
think
done that.
again, Nirmal, if there's only minimum, the small size, where is it? No portal
Right.
congestive
Yes, no
gastropathy.
portal congestive
Then
gastropathy,
you
correct.
can try even endoscopy, but surgery absolutely no. Again, we need to have not all the patients of obesity can be treated with the surgery alone, but they come with the comorbid disease, severe comorbid disease. So I think everything has got a role to play, but ultimately, if you ask me, if there is not much of comorbid disease, the surgery is the best if the BMI is more than 40 and you are able to do that. Any question from my Bangladesh colleague, Dr. Farooq, before I will go on to Dr. Pooja again? Dr. Farooq, while he is getting ready for the question, Dr. Pooja, your turn now comes.
Yes.
What is the
Well,
question? Now, second round onward, we want to have a rapid fire, brief question, brief answer. So we have around 45 questions to be taken. Well, let's see now. Okay, Dr. Pooja, please.
yes. So just looking at the questions, we've covered quite a bit of ground. I think what I'd like to ask and take the question, what do you think the role of gastroenterologist is in long-term follow-up post-bariatric procedures, specifically with dumping syndrome, nutritional deficiencies? If both of you can touch on that.
You're asking Dr. Mohit the question, post-bariatric surgery follow-up by a gastroenterologist. What follow-up?
Oh, yes. What
Yeah.
follow-up from Dr. Bhandari, and also nutritional deficiency, if Dr. Gokul want to comment, what should our audience know, both from a surgeon and interventional bariatric endoscopist perspective, and also from nutritional deficiency perspective?
Yeah, with regard to the nutritional deficiencies following endobariatric procedures or surgery, I think one need to take care of, need to check the macronutrients as well as micronutrients. Of that, I think iron, serum iron, we're checking the hemoglobin, vitamin D, because vitamin D absorption needs to be good. supplementation with folic acid may be important. B12 deficiency, because you're doing all these gastric procedures, vitamin B12 is very important. So all these levels has to be monitored and supplemented as and when required. So this is what I would like to tell. Of course, with orlistat, we have to take care of the fat-soluble vitamin deficiencies. And very rarely with this drug like topiramate, which can cause acidosis, one need to look into bicarb levels and again the bone loss by doing a DEXA scan. So this is grossly what we should look. That's what I think.
Dr. Mohit, your take on which type of surgery? I won't tell my personal experience. I mean, personal mean a patient I've seen. A patient had undergone duodenal, the ileal, the switch bypass surgery. They come with such a severe malnutrition I've seen. In fact, we had to rehabilitate with the nutrition. I think Dr. Gokul also will recall that she had lost tremendous amount of weight and all kind of nutritional deficiencies were there. She was not even able to move around that one. So we found out all kind of deficiency, and I found in that major surgery, bypass surgery, ileal. What is your experience and how do you tackle that, or how do you prevent it, Mohit? I think Pooja has a very important question. Okay.
Yeah, I think it's very important that we do not offer this kind of procedure like you are saying, duodenal switch, to a patient who cannot afford the cost of the supplements, or who cannot come for a follow-up, or who is not compliant enough. These kind of procedures, which are malabsorptive in nature, should be done for patients who have the affordability for the cost of supplements in a country like India. They should be ready to come for a follow-up, should be very compliant. And as Gokul clearly said, B12, D3, iron, calcium, folate, micronutrients, and trace elements. There needs to be a good supplementation of these every 6 months. If we do that, those kind of very, very radical procedures. Now for Indian perspective, we know, and you also know, Professor Chandrasekhar, that patient who come to us for simple gallstones, they have so low albumin. So I think Indian scenario, we should be avoiding procedures like duodenal switch. They are strictly meant for foreign patients who eat a lot of meat, beef, and pork. For us, I think sleeve gastrectomy, gastric bypass, or a very tightly calibrated one, anastomosis is a very good option. And they are doing great work as far as weight loss is considered. So that's part one of the answer. And the second, about the role of the gastroenterologist, which Pooja asked. I think now gastroenterologists are no more bystanders. They are a co-pilot, so there is a captain and then there is a co-pilot, so the first officer. So now the gastroenterologists have become the first officer, because in my practice I cannot work without a guest. We need to have 3 full-time gastroenterologists with us. We do close to 250 procedures a month, bariatric procedures. And every procedure there is some or the other issue. Sometimes you need them for strictures, bleeds, leaks, stenosis. So it's a huge, and the follow-up endoscopies every day, 10 to 15 follow-up endoscopies post sleeve, post gastric bypass. So gastroenterologists have a huge role in bariatric endoscopy surveillance, managing the complications, and helping us to deal with weight recidivism also. We did not talk about weight regain. Now the endoscopist and Professor Pishmal would tell you, she had fantastic papers on gastric bypass weight regain, sleeve weight regain, and so from our center. So gastroenterologists are no more bystanders. They are now the co-pilots, they are now the first officers, and soon they will become the captains.
I agree your attitude is the reason for your success. So you said the gastroenterologist, co-pilot or captain, and the kind of work. So you follow very inclusive medicine and include everyone in the team. That is the reason for your success. And this is going to be what in a bariatric thing. Before I move on to Dr. Pichamal, in Kerala, the mini bypass is very popular. What is that mini bypass? Bariatric, Dr. Mohit. What is that mini
Yeah,
bypass?
mini bypass is common. Mini is a small. It's a wrong word. It's a one anastomosis gastric bypass. So unlike the conventional gastric bypasses where we had two anastomoses, one is a gastrojejunostomy, the pouch with the jejunum, and the other was to divert the bile from the pouch. Now what you do, you just do not do two anastomoses. You just make one gastrojejunostomy, but the pouch, the length of the pouch is now 18 centimeters. So it's too far away from the gastroesophageal junction. So the bile does not go up into the G junction. Whereas if you talk about the old gastric bypass operation, where we used to make a very small micro pouch, the Phoebe pouch, which was 2 to 3 centimeters. If you do not divert the bile will go into the esophagus and patient will vomit bile. But the mini bypass is where we just need to make a very long pouch and just single anastomosis. That's why the name mini. And it's very popular. It's a fantastic procedure. The quality of eating is phenomenal. And recently, last 3 years back, even USA approved the ASMBS American Society also approved this procedure.
Okay, we'll move on. Thank you, Mohit. What is that, Dr. Pitchmall, your question and comment? And yes.
Yeah, thank you so much. And I have a question for Dr. Mohit. Like we truly believe in combination therapy. During the two amazing lectures, we discussed combination of medication endoscopy or medication with surgery. Dr. Mohit, you are a pioneer in combination of endoscopic and surgical procedures with your new ESG plus or ESG plus magnetic anastomosis. So can you tell the audience a little more about this exciting field? And from a technical standpoint, do you do ESG first or the magnet first? And do you place the magnet at the antrum or at the duodenum? And the reason why you place one or the other?
So beautiful question, Sai. As usual, you are brilliant, and
I love that procedure. So I need you to talk about this.
so people should know that the magnets I'm using today have been developed by you and Professor Chris Thompson. So the pioneering work have been done by your team. I should not take the credit. The credit goes to you. But yeah, I wanted to tell everybody that we are talking about ESG 2.0. And that's why I'm saying that this is going to move away from bariatric surgeons to the gastroenterologists. We will be no more involved, or maybe we have to learn endoscopy. Because what is happening now is what Professor Sai is talking. We are now doing a duodeno-ileostomy or a gastro-ileostomy or a gastrojejunostomy in combination with the ESG or an endoscopic sleeve gastroplasty using the endoscopic magnet. So what we basically do is that we come up with a therapeutic scope, and the therapeutic scope has the magnet attached to its tip, and then we deliver the magnet into the duodenum, and then we bring a loop of the bowel where we do an enterotomy, put another magnet there and close it, and attach both the duodenum and that loop of the bowel. So it's a duodeno-ileostomy, or you can do the same gastrojejunostomy. Now, the part of your question, I usually do the anastomosis above the antrum, a little above the antrum, because antrum is very thick. So I choose the body to do it. And then I do the ESG afterwards. So I do not do the endoscopic sleeve. I first would go down, and we put two very small ports, 3 mm. So virtually nothing on the abdomen. I would come in with the, and Sai, nowadays we have the Arthrex scope, which is a needloscopic scope. It can go through the umbilicus, and you don't need to even close the defect. It's like a Verus needle, 3 mm scope, which goes through the umbilicus. So we put it, and in the guidance, we put a small magnet into the bowel, close that defect, and then we go with a therapeutic scope and deliver the magnet either into the body of the stomach or into the duodenum, and then we anastomose both, and then we do the ESG. The magnet, the autolog device, if it's there, passes off within 48 to 72 hours, and the magnet would pass in the motions around 7 to 14 days. And the patient would complain of severe nausea after 7 to 14 days. And suddenly the ESG becomes so much more powerful. So that's ESG 2.0, and that's going to be the future. And I can see that the device being approved in US, this is going to be completely game changing. And most of these surgeries would be like this, what we are talking about now.
Okay,
Very
very
exciting.
nice, very good. And I just want to ask all the people, the panelists and the faculty, Before I ask a question, I just want to clarify one doubt. If you want to get the bariatric, that obesity medicine certificate, is there any criteria that candidates BMI should be below something?
No, it's not.
I'm
It's
just
not.
asking in the lighter sense, the Dr. Sai, the BMI also calculated before giving the certificate for the candidate. So both of you looking very. I think Gokul is qualifies for that first because he claimed that his BMI is 20. So he's a fit example. And Tanti also will get it, and you also. So anyhow, my question is: people ask lot of question about. Sir, there are umpty number of diet formulas available, ketone diet and other thing. So what is your take? So each one will tell about one diet and tell the what is the importance or anything like that. We'll start with Dr. Mohin. I think you would have seen so many patients come with all diet formula. Okay, what about ketone or fasting and other thing? Because you want to have a relief from the endoscopy, medicine and other thing. Okay, we'll start with Dr. Mohin. So intermittent
So yeah. So my answer is that I am not a believer of a diet. You may take any diet you want, but the principle is negative calorie deficit. If you are on a ketone diet and you are taking 10,000 calories in a day, it's not gonna cause any weight loss. So you do paleo diet or do you do keto diet or you do intermittent fasting, the principle is negative calorie deficit. That's the principle. So diets don't does not matter. If you are doing intermittent fasting and in the eating window period you consume 5,000 calories, then how does it matter? So the principle is negative calorie deficit. I don't believe in diets. That's my answer.
What is ketone diet to do with puja?
Yeah, so there, I completely agree. This ketone diet, the carnivore diet is the new trend as well in TikTok in US. I also very much believe in mindful eating. And the word diet itself has such a negative connotation because it should be sustainable. And in the world of obesity medicine, really the Mediterranean, if you would follow something, it would be like the Mediterranean balanced, healthy fats, good meat, not avoiding fried fatty foods, good vitamin and mineral rich foods is really kind of what is a respected way to quote
Okay.
unquote diet.
Your take is the Mediterranean diet. Okay. What about paleo diet, Dr. Pichamal? What is your
So
opinion?
yeah, I mean, I think I totally agree with Dr. Mohit. In the end, you want the diets that are low in calorie compared to your requirement. And it has to be the diet that you can stick to. So it could be paleo, it could be Mediterranean, but
That
as
we
long as you don't.
understand. Now, for the sake of the audience, why the concept? I agree with you that whatever my best diet, I always tell the patient is you eat whatever you have been eating, but only thing is reduce the quantity and do exercise and the quantity in such a way that you should have a calorie deficit. That we'll understand that. Somebody wants to know why the ketone principle came, why the paleo. That's the thing I'm asking.
I mean, for paleo, the data is more on cardiovascular disease. So more like you get the weight loss, but also you get more effect on cardiovascular disease. For keto diet, because you are focusing on protein, and when the body is digesting protein, it burns more calories compared to when the body is digesting carbohydrate. So it helps in the end to have more calorie deficit. And that's why people are hyping up about keto diet, for example. But in the end, you still have to do the calculation and make sure that you eat or consume less than what the body requires.
What's the diet that Gokul you suggest intermittent fasting? What is your take on that? Or
So intermittent fasting is very popular. So generally, they give a fasting period of say 12 to 16 hours, and then the rest of the 8 hours is actually the period where they tend to eat. And this has been popular since many days because of Ramadan. Because during Ramadan they used to fast for these 16 hours, and they found beneficial effect in those people. So this probably concept was borrowed from them. And studies have shown that not only weight loss, but there is also an improvement in metabolic profile, like improvement in diabetes, and also the lipids seen with this kind of a diet. So definitely it works, but ultimately it has to be a hypocaloric diet. At least 500 to 750 kilocalories of the total energy expenditure, calculated expenditure, one need to subtract 500 to 750. So that hypocaloric diet is what works long term. All these diets, as Dr. Pooja Singhal told, it has to be sustainable, because short term the results of weight loss is impressive, but long term they are not sustainable, and ultimately patient goes back to the original diet. So it has to be sustainable. That's what I think.
But in between, during fasting, suppose he's like a active endoscopy surgeon like Mohit, or from the Dr. Pichamal writing so many papers and doing endoscopy, Puja, how they sustain themselves in the during fasting time? How they are able to work? Is it possible to work with so much of fasting, 12 hours, 16 hours? Anybody has done the intermittent fasting in the group? No. Dr. Tanzan says, well, huh? Yes, Pooja, you have done it?
I think to a certain extent, we probably all have done it during training or other parts of our careers, but I definitely have done intermittent fasting. I was curious to try it, and it's amazing that personal experience, the body really does adapt. And it's the concept of hyperinsulinemia that, the body profile changes, like Dr. Gokul said. And the first 24 to 72 hours are probably tougher, but after that, your pattern of appetite, hunger changes, where you are able to kind of adapt and reserve.
Can we take it, Mohit, as a pre-surgical test? Those who are able to fast, they'll have a better willpower after surgery or after endoscopy procedure. Okay, they have been tested and they will follow the willpower of before removing the balloon or something like that.
Uh, I have a very different take on it. I don't think uh, bariatric surgery or obesity is a game of willpower. It's more about metabolic, genetic, hormonal issues. There are patients who might eat less, still have that kind of weight. So, if you really ask me about the preparedness for the surgery or surgery
Yeah,
readiness
preparedness.
for, yeah, those are the questions. So my surgical readiness would depend more upon their psychiatric evaluation, where I do not want them to have a binge eating disorder, or maybe depression, or maybe a substance abuse. That's very important for me. I don't believe. I'm sorry, I don't believe in willpower. It's something we have been using to insult the obese patients. So we don't believe in that concept. But what we believe in is that we should rule out completely three things. As I said, substance abuse, depression, any major psychiatric illness, binge eating disorder, and things like that. And also at the same time, we also would ask certain questions to the patient about the kind of motivation they have, the kind of lifestyle adaptation they are ready to do. That to me is a more important test of surgical readiness than simple willpower, because willpower is not objective. It's a very subjective philosophical thing. I don't know if Pooja will agree with me or Professor Sai would agree, but that's my way of working.
Okay, Dr. Evaris,
100%.
Dr. Evaris is your question, and followed by Dr. Tantan.
Thank you.
Yeah.
Look, Mohit, so I have a question for you, Mohit. I want to find out for your patient that have had bariatric surgeries, have you encountered a situation where after some time they start gaining weight? And if it happens, what do you do in patient that had bariatric surgery? And at a point they now start gaining weight, they will start increasing weight. What to hear? I want to know your experience in your practice, because you have a lot of experience. Patient will hear about patient having dilated gastrointestinal anastomosis, now gaining weight. And how common is it in your practice, and what do you do?
Oh, it's very common. Almost 50% of our patients gain weight. It's very common. And what we do, we bring them back to the clinic. We do a complete evaluation, like you said. We do a radiology, we do a endoscopy, we check the pouch size, we do all the hormonal profile, we take a complete diet recall. And once all these things are done, most of these patients would go to an obesity physician, where they would be put on injectable semaglutide or tirzepatide for some point in time. If they respond, well and good. They will have to go on a chronic GLP-1 therapy for their life. If they do not respond, we escalate this to endoscopic revisions by doing an endoscopic outlet tightening, pouch reduction, or a endoscopic sleeve gastroplasty of the sleeve gastrectomy. And if even that does not work, we combine the endoscopic procedures with the drugs. And God forbidden, if that also does not work, and we have passed an year or so, and patient has still is on a complete path to gain that weight back, we convert these procedures from sleeve to a duodenal switch, or aside from bypass to distalize them, or from one anastomosis to further distalize them. So it's a very complex situation. As you correctly said, it's not easy. And with 50% of the patients gaining some weight back, I would again say we need all the three friends. We need the obesity physician with us, absolutely with us, the most important. We need the endoscopist, the gastroenterologist with us. We need the team with a surgeon who can manage these patients if both these fail. And at the same time, a lot of psychological and mental work goes into this entire exercise. Weight regain is a very complex thing to manage, and you need a team.
Thank you. Dr. Farooq, you want to ask him, Dr. Farooq from Bangladesh? Okay, well, he's getting
Yes, sir.
ready. Yes, please, your question or comment. A brief question and comment. We have only 10 minutes to go now. We'll wind up. And I need 8 minutes for the final round to ask something more about this. Okay, Dr. Tantan, Farooq, your brief question.
Thank you, sir. For us in Bangladesh, actually, we are very in primitive stage still for obesity management. Only thing that we can use the drugs which are now recently available. And regarding endoscopic procedure, there is we are not doing this endoscopic bariatric procedure, and somebody is doing some surgical procedure, but these are very scattered, and there is no organized course or clinics for obesity management.
Actually,
But drugs are now easily
obesity,
available.
as is Dr. Mohit correctly said, obesity is a very, very difficult ball game to treat because obese patient doing surgery, a lot of morbidity may be there. So unless you are an expert, you run a program, and it is not even anybody can be, even a poor man can be obese, but managing it also it takes a lot of time and energy and money consuming also. Dr. Tantan, last question before I take up the turn.
Yes. Yes, I would like to ask Dr. Gokul regarding the adverse effect of semaglutide. And the first question is how to choose oral or injectable form of semaglutide, and how to handle gastroparesis related to semaglutide, because it is very common adverse effect.
Yeah, so because these drugs causes reduction in GI motility, so this nausea, vomiting, and this problem is quite common. So the thing is, we have to gradually titrate the dose. For semaglutide, we start with 0.25 given every week for first month, and then we escalate by 0.25 milligram every month. So this dose titration is very important. Along with it, we always advise patient to take small meals because that is quite important. It is very important to make sure that the patient doesn't have has gastroparesis to begin with. So in a diabetic patient, this is very important because they can have gastroparesis earlier. So if needed, we may have to do a scintigraphy or the test to rule out this gastroparesis before starting this drug firsthand. So that is how we go about. But this adverse events with this drug is quite common.
Okay, thank you, Dr. Mohit. Brief comment on plastic surgery. Suppose pendulous abdomen, everything. I think you need to combine after the bariatric surgery. What is your take?
Yeah, we have a huge bariatric plastic surgery department. I work with 3 plastic surgeons.
That's what I was wondering. You did not comment on that, so I thought I will.
No, we have a very huge plastic surgery. In fact, I was trained by Professor Malfobi, who devised the gastric bypass operation, and me and Malfobi, we both used to do a lot of these bariatric plastic surgeries together when he was in India. I myself did a lot of abdominoplasties, breasts, thighs, but now there is too much of volume in my unit, so we have 2 or 3 plastic surgeons with us who do all these kind of procedures. They do a total body lift, abdominoplasties, breast reductions, mastopexies, arm and thigh reduction, everything. Yeah, it's a pretty busy unit we have because our own patients come to us. And now with semaglutide and tirpazetide, huge number of patients that come to us for facial lasers and every other. So maybe bariatric aesthetic, bariatric plastic surgery is growing in a very big way, more than bariatric surgery.
Okay, now we'll come to the end of our program, the lighter session, and for that, ultra fast and we have to ask the answer also very fast. Question start. What is your fitness mantra, Dr. Mohin?
I would want to go on a negative deficit. I would believe in calorie counting, and also, keeping myself active, doing a run or maybe bike or maybe swim whenever I get the time. That's it. But negative deficit is most important. If you do a lot of exercise and consume four times the amount of calories, you'll never lose weight.
Okay, Dr. Pichamal, what is your fitness mantra?
Weightlifting, so that you can keep the muscle mass in, because muscle can burn more energy.
That's very important. So weightlifting, you do that. So people think weightlifting only for men. So it is not so. That I think for women also, at least in India, I can tell you that weightlifting means for only for men. I think weightlifting is very important for muscle mass. What about Pooja?
I absolutely love swimming and dancing. So water aerobics is very good. And I also sleep, concentrating on sleep.
Okay. Then Gokul,
Sir, if I don't find time to
don't tell me that I'm not giving time to leave home. Okay.
so if I
He's
don't
working
find
with
time
me.
to exercise, I eat less because that is how I do. And flexibility is very important. So I do yoga and Tai Chi daily.
What about our Nigerian colleague, Dr. Evaristus? Quick, your mantra.
Yeah, I eat less. Yeah, I eat less and I also do
Okay. What about Dr.
play
Tanta?
football when I have the
Yes,
time.
I also eat less and I morning walk. I do morning walk.
Morning walk. Okay, now you please tell me that what is the famous quotation you really love and want to pass on, Dr. Mohit? The quote.
Quote, I think the one quote I always like in my life is that enthusiasm has real magic. It spells the difference between mediocrity and accomplishment.
So that is the quote that really motivates you and very
Yeah.
enthusiastic,
I
positive.
think if you're not enthusiastic about something, if you don't love something you do, you're gonna be mediocre. You will never
Okay.
accomplish.
What
So
about Pichamal? Your
For me, it's the kind of like the rule of 80/20, like everything in moderation, so that you can get a lot done. You cannot be a perfectionist on
I
everything.
heard this many people telling that nothing in excess but everything in moderation is the quality of life. So that's what. What about Pooja?
I really go by be so good that they can't ignore you. I mean, there are many, many quotes, but that one is
No, only
probably
one now because we don't.
yeah, that's it. That's in my office. Just be good at what you do, and
Okay. What about Gokul?
Sir, it is not important what happens to us, but how we take it. So that is what I
You
personally.
mean the attitude. Very good, very good. So anything can happen to anybody, but how do you take it is very important. About Evaristus, what is your quote?
Yeah, I believe that changing the world
Okay.
starts with me. Sometimes we all talk change the world, but it starts from me. So that's my take.
Okay. Tanthan, what is your
Yeah, you just make each day your masterpieces if you're interested. Yeah.
what is that? Can you repeat it?
You just make each day your masterpieces. Yeah.
Okay.
Your skill. So you like the masterpieces, you have to do it every day.
Okay, quickly now, what is the non-medical book you have read recently apart from obesity and gastroenterology? Dr. Mohit.
Recently, some novels. That's it, Robin Cook novels, but nothing.
Do you get
I'm
time,
not a
Mohit? I thought you don't get time to sleep also. There's so much of
no.
sleep.
I get time to read. In fact, if you ask me very recently what I read my daughter is writing a book. She's 15 years old, but she has written a huge collection of poems, and that book is going to be released. So I read the entire book,
Okay, fantastic.
proofing it.
Congratulations to your daughter. What about your Pichumal? What book you have read?
I mean, most recent one was on functional health, but I don't know if that counts. Before that was kind of like the turning point.
What about Dr. Thank you. Dr. Pooja?
So recently, I'm in the middle of this. It's a book written by a neurosurgeon. When the breath becomes air. He passed
Yeah.
away. He wrote a book. I haven't finished it, but I started it. It's very impactful. So
Okay. Dr. Gokul?
Sir, I'm interested in psychology, so I read non-fiction psychology books. I'm in the middle of a book called Mindset.
I did not know that kind of mindset you have there. I meet him regularly every day. And okay, thank you, Dr. Evaristus. What is your book you have recently read? While you are recollecting, Dr. Tan?
Yeah, I'm sorry. Currently, I cannot read any book rather than the.
Okay, right. Now, the penultimate. Who is your famous hero and heroine? Mohit?
Hero and heroine. I see a lot of Bollywood movies, so maybe Amir Khan, and heroine. I do not remember. I've not seen movies since last so many
They're
years
very
now.
shy, I think.
No,
Okay.
uh,
A hero can be your father also. Heroine can be the kind whom you want to emulate also. It need not be. Okay, Amir Khan, really like it. He's a good actor. Who is your favorite hero and heroine, Pitchmall?
Oh, favorite hero. I mean, I recently watched Formula One, and Brad Pitt was pretty good in it. So
Who that?
Brad
Brad
Pitt was
Pitt.
in Formula One, yeah.
Brad Pitt, huh? Okay. What about Pooja?
oh my goodness, that's a loaded question. But besides my parents, I would probably say Shah Rukh Khan and probably Rekha, the
Rekha.
old.
I think you got old to the, what is that famous mirror, John, huh? What is that? Okay, that is the movie where she
Yeah.
got the national award. What about Gokul, your favorite hero and heroine?
I often, I mean, don't watch movies often, but still, I would like to tell about Kamal Hassan as my hero in Tamil movies. Yeah.
Okay, heroine, you want to reserve yourself. Okay, right. What about? Okay, Evaristus, you watch some Hollywood movies?
Not really. I don't have time
Okay,
most times,
or you
but
tell me who is your sports personality that whom you like? You
I, I will start with our Super Falcons for Nigeria. Now
okay.
that's the team that
So,
just won
Tanthan, you
African
watch,
World Cup.
thank you. Tanthan, you watch Wimbledon tennis? Did you watch?
Yeah, I also watch Bollywood movies.
Oh,
So
you
my
watch,
favorite
very
is,
good.
yes, my favorite is Amitabh Bachchan.
Oh, everyone likes him. That I think that is
Yes.
universal. Apart
Yeah.
from one word. Anyway, ladies and gentlemen, now it's a 9 o'clock now. We had a wonderful session, and Mohit is super, super, super because the kind of number of cases, the series, and the wisdom, the pearls of wisdom, he really made it. And the way he developed the confidence, starting from a very humble background. Actually, we can interview Dr. Mohit for an hour. So we'll have a separate session. You are actually the pride of India. So because of the bariatric, and I appreciate the kind of efforts you're doing. Huge. You have a number of cases that is unbelievable, and you rope in everybody possible. And it was nicely moderated by Pichamal. She was so humble, despite having from so much of publications from Harvard. I appreciate your the sincere comments and the other speaker, Dr. Gokul. It's a very difficult talk to prepare actually. To prepare pharmacotherapy, everything about medicine. He has got a passion for pharmacology. I appreciate Gokul. They did a wonderful job.
Yes, sir.
That one particular slide was so good. The adverse effect, BMI, and the type of drug you give that. And Pooja, you did a fantastic job asking and moderating, the giving a relevant comment, and and even the later session, all of you did so well. And Dr. Tantran, your Myanmar, despite a lot of rains and the internet problem, you were logged in. Everest is exposure to the international arena. Thank you, and other ambassadors. It's a wonderful time we had it, and it has been recorded now. You can get it in YouTube in 2-3 days time. Okay, thank you, and ACG
Thank you.
sends regards to all of
Thank
you.
you, everyone.
This is a ACG endorsed webinar, so you can put it in. We are going to put it in YouTube. We'll cut it.